Hi, everyone. Can you guys hear me? I hope you guys are having a great day out here in Disneyland and enjoying all the talks and lectures. It's my privilege to introduce Dr. Veedu. I know some of you in this room know Dr. Veedu. I'm one of the sponsors here, so I get the opportunity to connect with the speakers beforehand. And so Dr. Veedu, for those that don't know, he's an epileptologist serving the Central Valley based out of Bakersfield. He is triple board certified and the medical director of the Kern Medical Epilepsy Center. He is a member of AAN, American Neurophysiology Society, and AES. He has a vast wealth of knowledge and experience, and he has been trained at the Cleveland Clinic, and he has been in the Valley for about 7 years. So you're in a real treat for his talk, and enjoy.
Thank you for inviting me to participate in this conference. So usually this kind of conferences, you will be invited to people from big academic centers, but the reality is that a majority of the patients having epilepsy are living in a rural area, either California or any state. And there is no real actual representation of these people in any other committee, including the American Epilepsy Society, American Clinical Neurophysiology Society. So, but at least the organizers noted that point and give me an opportunity to express my experience. So then I was looking, what should I, present to the audience? So then there are a lot of big faculty members from all the different universities throughout the country discussing about the various different aspects of epilepsy, mainly focusing on the refractory epilepsy, surgical options, different medications, and all the things. So I want to say something which is different, not really often talk about in the entire country scenario. Because when you talk about epilepsy, you always talk about the worst scenarios, like refractory epilepsy, surgery, and all the things. Because the epileptologists are interested in that. But in the real world, 70% of the patients are well controlled with the medication. So, and they can move with their happy life. So then how do you make this diagnosis of epilepsy? The most important is the semiology. Second is the diagnostic test we have. So the diagnostic test is the biomarker for the epilepsy is the electroencephalography. Then you can, supplement it with the neuroimaging testing, genetic testing, and everything. So then, how much is efficient this EEG in making actual diagnosis of the spell? The spell can be really an epileptic spell, or it could be a psychogenic spell, or any other paroxysmal events, like vasovagal syncope and other syncope. So I just want to dive into the actuality of the yield of this test. First I will tell you the data, and then I will actually go to my own experience of doing this ambulatory video EEG monitoring, routine EEG, and EMU evaluation for several years. So this is the classical definition of epilepsy. When you have two unprovoked seizures in 24 hours apart, or one unprovoked seizure plus another evidence that he can likelihood develop one more episode in the next 10 years. That probability is defined by an abnormality in the EEG or a neuroimaging testing that suggests that potentially he can have another similar paroxysmal or different paroxysmal event in the 10 years. That is the official definition of epilepsy. Or you can have one seizure, but you did an EEG that shows the classical picture of an epilepsy syndrome. This usually fit in the pediatric EEG group. Then definitely you make the diagnosis of epilepsy. But what is the problem of just making a diagnosis based upon the semiology, means the clinical signs that is a patient or the family describing? Because they, first of all, they'll be very nervous and tensed, and also it is very difficult to give a very comprehensive, detailed description of the semiology. But nowadays it is changing because when you have this recurrent spells happening, most of the people record this episode in the video camera and bring it to our clinic for evaluation. So we can very systematically evaluate the semiology and you can put into different categories. So basically the epilepsy you need to have into two different categories. Either is it a primary generalized epilepsy or it is a focal epilepsy. Focal epilepsy means starting from one part of the brain and spreading to the entire brain, or it can be just in a focal area. And the manifestation of the symptom based upon the area of which part of the brain the seizure actually starting. Primary generalized epilepsy means a bilateral hemispheric network is firing simultaneously. So the manifestation can be either a motor, generalized tonic-clonic seizures, or it could be just like a loss of awareness. This is called absent seizures. So this is the main headings under which we classify the epilepsy. Focal epilepsy with aware seizures, focal epilepsy with impaired awareness, and then focal to bilateral tonic-clonic seizures. Majority of the time when the doctors say you have a generalized tonic-clonic seizures, it is actually focal to bilateral tonic-clonic seizures, because more than 70-80% of the seizures are actually focal epilepsy. Then, generalized epilepsy, as I told, you have two broad categories. One is the generalized tonic-clonic seizures and absent seizures. So, but like it is very difficult. Most of the time when you go to hospital, you don't have actually you cannot describe the symptoms, and also you don't record the video. So then we need to make a diagnosis, because once you make the diagnosis, this diagnosis stick to you the rest of the life. So we should have a really high yield test to confirm the diagnosis of epilepsy. For other conditions, you have, other medical conditions, you have very definitive diagnosis. The doctors are not just depending upon what patients are telling. For example, you have diabetes. They don't care your symptoms you describe. You have hemoglobin A1C more than this level, you have diabetes for sure. So, but we have only one biomarker for epilepsy is the interictal epileptic discharges, or like a repetitive building up of these discharges or repetitive rhythmic activity evolving over the time is called electrographic seizures. And then when you have an epilepsy, there'll be supportive evidence like MRI shows of so many different abnormalities. You can hippocampal sclerosis, or you can have encephalomalacia or a scar. Everything can cause epilepsy. But the clinical manifestation of the seizure depends upon primarily where the seizure is coming from. But I also want to tell that just seeing an MRI is abnormal doesn't mean that patient has epilepsy. You have to have the clinical symptoms, and then you may or may not be lucky enough to have a correlate of EEG. So then another category of genetic epilepsy. So again, just having a genetic mutation doesn't automatically mean that the patient has epilepsy. It has to have the the semiological presentation and a corresponding EEG. Only then that patient has epilepsy. So as I told, the only available real true biomarker for epilepsy is the electroencephalography. So before diving into the moral advancement of the EEG, let me talk about the historical aspects. The first recording of the electrical potential of the animal was performed in the 19th century by a British physiologist. His name is Richard Catton. And after that, several years later, in 1924, a German psychiatrist, Hans Berger, recorded the first electroencephalography in a 17-year-old boy. So basically, there is an interesting story behind that. He's he's strong believer in telepathy. Why strong believer in telepathy means that first, because of the World War I, he was commissioned to work in military. Then one day he fell down from a horse. So somehow his elder sister, living in a remote area, she felt that something happened to this guy. So she asked her dad to send a telegram to this person. So same day evening, he got a telegram. So he just strongly believed that mind can communicate each other. So he became a very strong believer of telepathy, but he need to prove it by a in scientific way. So he started the whole research of this electroencephalography. First he started, because he already had animals done the electrical potential recorded from the animals in the 19th century. So he started recording the electrical potential from the open skull in the craniotomy surgery. And after that, like a patient with a skull defect, he recorded. Then, the galvanometer, amplifier, all quality improved. Then he started recording from the scalp EEG. And the first he recorded the scalp EEG of himself and his son. So then, this all the science from the Europe came to USA, Boston. And then, the Lennox and the Dr. Gestard, these are the pioneers who started the first EEG lab in Mass General Hospital, and then recorded the EEG patterns associated with the different epilepsy syndromes. The Lennox-Gastaut syndrome, the most well-known refractory epilepsy in the pediatric age group. So this is Lennox and Gastaut that described that. And not only that, he described the epileptic abnormalities seen in so many different epileptic conditions. So again, now for many decades, we just have this, probably Adora may know this, we have this in a paper EEG. It is like you cannot even change settings, and it is just a paper, the analog EEG. So in 1970, what happened, early 1970, the digital technology it came, and from analog to digital EEG is changed. So it totally revolutionized the way we do EEG. Now you can change the montage, and you can record for like a variable length of duration, and you can eliminate the artifact. So all advancement happened in 1980s. And Dr. Ebersol, he's still alive. So he in 1980s recorded the ambulatory EEG, integrating with the EKG channel as well as event marker and time display. So that is what is the inpatient video EEG monitoring and ambulatory video, which is the essential part is like continuously running the EEG, integrated with the push buttons and then EKG. So then later on, the video also integrated now. So then the first epilepsy monitoring unit is established in University of Northern California, North Carolina, and that was like initially they have the analog machine, and then later on transitioned into the video EEG machine. So these are the major historical facts. One is the Hansberger, and then Dr. Lennox, and then ambulatory EEG. So then coming to this EEG, the usual word is a routine EEG. Routine EEG means you do EEG for 20 to 30 minutes. And how much it is actually showing you have an epilepsy? Actually, the yield is very low. The sensitivity of the test is only 29 and some days 55%. But in reality, if you do an EEG for a small kid with really refractory epilepsy, or for that matter, an adult with really refractory epilepsy, it shows some discharges for sure. But if you have like a one seizure, like a couple of months, one seizure per year, most of the time this test is actually negative, to be honest with you. So we in Central Valley stopped practicing this so-called routine EEG. We just directly do 2 or 3 hour EEG, because we know that it's kind of waste of our time and patient's time too. And as we expected, but when you see the discharges, when you know the location, you can tell it is a focal epilepsy or it's a primary generalized epilepsy. Focal epilepsy means we put the electrodes, targeting different lobes of the brain. If it's a frontal electrodes coming, frontal lobe epilepsy. Temporal lobe epilepsy. Occipital electrodes, it is main negativity. It's the occipital lobe epilepsy. So the specificity of the test is really high, but the sensitivity is low. Even though all these official studies reporting 29 to 55%, if you're asking honestly, 20-minute EEG, I think the yield is like in an adult world, it is like 5 or 10% only. I don't know whether Adora agree with me or not. So, and then, so the limitation of the EEG. So it is always prone to misinterpretation by, overzealous people. There are a lot of benign variants, and especially just the young epileptologists just to train out of the program, they overcall the things, everything is abnormal. And then, it is always like corrupted by artifact. You should have a really good training to differentiate between artifact and the actual epileptic discharges. Otherwise, you will over-treat. And sometimes you under-treat too. So what are the factors that affecting the sensitivity of the EEG? As I told, the region and the type of the epilepsy. For example, if the epilepsy is coming from the mesial frontal area or like a orbitofrontal part of the brain, so it is so deep in the brain, the electrodes are at the surface, it will never express outside. It is not never, it will very unusually only you see the epileptic discharges seen in the cortex. So, and then age of the epilepsy, like a younger age group, you have like a lot of specific pediatric epilepsy syndrome. They, like routine EEG shows like really positive discharges. But as I said, like in adult, relatively well-controlled epilepsy, the test is negative, most of the time negative. And then activation procedure, hyperventilation, photic stimulation, bring out the epileptic discharges, and level of consciousness. If the patient is sleeping, the epileptic discharge is going to be high. And the anti-seizure medication. So when you think patient had epilepsy based upon just based listening to the story, you start some medication. What happened? EEG is going to be it will suppress the intraocular discharges, and when you do the EEG in the lab later on, you are not going to show the discharges. So that is why when we bring the patient to epilepsy monitoring unit, we stop all the medicine, and then you can see like epileptic discharges and electroclinical seizure is coming up. So again, as I mentioned, seizure frequency. Infrequent seizures, test is negative. Frequent seizures, more likely you see something in the EEG. And quantity of electrodes. Usually in the standard setting, like a 19 to 21 electrodes are we placing. But now the most of the Scalp EEG machines has 64 channels. I think Cadwell has like a 34 channel or something, but Nihan Kodan definitely has 64 channels. But now there is a high density EEGs. You can have like several more than 200 electrodes, so they can really sublocalize the area where it is coming from. The spatial resolution of the test is improved with the time. And the duration of the EEG too. So that's a key thing. So if you allow the EEG to run for several hours, several days, then the chance of like discharges is, you are able to find discharges high. So since we are running this EMU and in majority of the university hospitals, they mainly rely upon the epilepsy monitoring unit because they have like a 6-bed, 10-bed epilepsy monitoring unit. But we just have only 2-bed EMU, so we cannot rely everything on admitting the patient to the hospital to record this. So most of the, many times we do like a outpatient EEG monitoring called ambulatory video EEG monitoring. And majority of our inpatient EEG monitoring, we restricted to patient we think they're really surgical candidate, but because surgery is our priority, or not a surgical candidate devices. Then, we just not failing that we are not able to record anything in the ambulatory, then we'll subject this patient for inpatient video EEG monitoring. So what are the pros of inpatient EEG monitoring? You can safely taper and stop the medication, and it is in a controlled environment with a higher chance of capturing events on camera, and on-site technologies to address the technical issues, and it is easy to perform the activation procedures and can address other medical needs that may arise. So this is a very important thing. So like in the ambulatory, you do at home, you cannot stop the medicine. When the patient go into a seizure, then you will be medico-legally liable. So we are more comfortable to do a test in the inpatient EEG monitoring. And and the camera also. So patient will be focused on the camera. So whatever the event is happening, we can really record in the camera. But when you do an ambulatory EEG monitoring, patient will not be sitting in front of the camera all the time. So when event happen, when out of the radar of the camera, so we don't know what exactly the event happens. So, but on the other hand, inpatient EEG monitoring is a very expensive test comparing to ambulatory EEG monitoring. And a hospital environment differs from daily life, potentially affecting the typical event occurrence. So the literature says that suppose the patient has psychogenic non-epileptic seizures, they capture more in the ambulatory EEG monitoring, but I'm not really sure that, because that is not our experience. Even this non-epileptic psychogenic episodes also, we capture more in the inpatient video EEG monitoring. So then one another limitation of the inpatient monitoring is that many of the patients are working, and so they cannot leave the work and stay in the hospital for 5 days, and the long distance to travel to come to the hospital. So those are all the limitations in inpatient video EEG monitoring. So again, this is just the same thing. Ambulatory video EEG monitoring, what are the pros and what are the cons? Pros means the cost of the study is per study is less for ambulatory video EEG monitoring, and the quicker access to service with a shorter wait time period. So if you, for our example, if you need to have an EMU admission, it takes like a minimum 3 to 6 months. But an ambulatory, probably you can do it in 1 month. So it is quicker to do. And so they eliminate the need for the family members to travel to the hospital and stay with the patient for about 5 days. So then they say that the higher likelihood of capturing this epileptic event in a home environment, but which I don't totally agree with that. And so it is better tolerated by patient than inpatient monitoring. That is probably right. And provide a regular environment and stress in which episodes normally occur. So again, that's also a debatable point. So comfort of being at home, and allows patient to maintain their daily routines. These are the pros of doing an ambulatory than directly sending the patient to inpatient video EEG monitoring. The cons are patients may not be on camera during event or may forget to press event button, and cannot safely reduce medication to induce seizure, and limited ability to address technical problems during recording, because some electrodes came off. Nobody can go to the patient's house and fix the electrode. So then the patient come back, it is a totally artifact in a study, then it is a waste of all our resources. Then cannot address other medical needs that patient may arise. For example, patient is when the patient come after 3rd days, we are reviewing the EEG, we saw a couple of seizures. Then we get feeling guilty. Oh, this patient went into seizure, and we don't do anything at that time. So that's a kind of even like a landing up in a medical legal issue. If we miss some seizures, and then other problem that absence of simultaneous high fidelity video recording in some cases, that's also a limitation of the ambulatory video EEG monitoring. But the technology is getting advanced day by day, and this is like all the challenges I already mentioned. There are kind of solutions are coming. And the scenario is changing day by day. So because the portability and wireless technology. So every vendor you talk here, they tell, okay, the new version came. It's a lighter weight, and it's a wireless technology, and the high definition video integration with a very high quality, and synchronizing with the EEG, getting more and more accurate, and cloud-based system remote monitoring. There are companies offering even ambulatory video EEG monitoring, and the companies, they read the EEG from their home, the technologists read from home. So that kind of technology is really coming. And the most important thing, as in every part of the medicine, is artificial intelligence and machine learning. So artificial intelligence algorithms are getting better and better, and they can analyze the EEGs and helping clinicians detect patterns more efficiently. So artificial intelligence in the coming years is going to play a very significant role in the interpretation of the EEG. So just for example, I'll just quote one study. This came in 2023 JAMA. So this is this is called SCORE AI. This is an algorithm, and that compared with the expert epileptologist, and their accuracy of reading the EEG is as good as an expert epileptologist. It's called AUC curve, means 0.89 to 0.96, means almost like a very good. So, but what is the limitation? Means even the so-called these tools we can only say the pattern that physician deciding these are the epileptic discharges and train the algorithm to look for that. But the problem that if you simultaneously record the brain activity and the scalp electrical activity, there will be electrical discharges happening in the brain, but it will not reflecting on the surface because so many layers to go. The bone and the dura bone and the skin. So, but now within next few years, there are going to be algorithms that is going to reflect the modulations that is you cannot see with our visual eye or any other technology that you are currently applying that change is seen in the changes in the surface EEG, but it can detect some underlying changes and it can tell you very accurately where the seizure is coming from, very with a micro precision of the sublobar localization. That is the way it goes change. So it means that it is going to become like a H1 hemoglobin A1C for diabetes. So you can really see the discharges and you can see a scale. Then there is no question: am I really having seizure or doctor unnecessarily pushing the medication? So current evidence of the ambulatory video EEG versus inpatient video EEG monitoring in the classification spell. So I just looked at the literature, what is available currently, comparing the efficacy of these two. Only very few literature, even though, a private practice neurologist and epileptologist in the whole country, doing this ambulatory video EEG for several days and everything, but there's no real concrete study comparing the efficacy of these two tests, only few studies. So one of the largest study is published in Seizure 2019, done by Said. So he compared, 9,221 ambulatory video EEG report and compared with 436 inpatient video EEG monitoring from two academic centers. And the final conclusion is that the epileptic abnormalities will be seen in the inpatient video EEG monitoring 76%, but ambulatory is 40.4. So it is obviously it is a less yield, but the conclusion is that is useful for non-urgent diagnostic evaluation. I agree with that, but still you can really see only 40%. So 60% of patient, you're missing. You don't know what exactly happening. So and then also another study published in Seizure in 2017. But here it's a small group, only 41 inpatient video EEG monitoring, 41 ambulatory video EEG monitoring compared with 64 inpatient video EEG monitoring. He come to the conclusion that typical attacks were occurred in 74% of ambulatory video EEG monitoring and 62% of inpatient video EEG monitoring. So that's a kind of, I'm not really sure it is true or not, but that's what his conclusion. So he's saying that ambulatory video EEG monitoring is a convenient alternative. So then this forced me to, because we are doing this test day and night. What is the truth lying? So I just, we thought we'll review our data and see where exactly, standing. So we are the only one adult epilepsy program in the Central Valley, and we just have only 2-bed EMU. And, so this is a retrospective review of a prospectively maintained database of patients undergoing inpatient video EEG monitoring with the ambulatory video EEG monitoring between January 2020 and January 2023. So then when the patient is sending for these tests, you make a pre-test diagnosis based upon the description of the clinical signs you think is an epilepsy or a psychogenic or other spell. In epilepsy, then based upon the chart I show, we have to say it's a focal aware seizures, focal impaired seizure, focal to bilateral tonic-clonic seizures, or generalized seizures. So we make a pre-test diagnosis, and after the test, you make a post-test diagnosis. So the post-test diagnosis you are making based upon the intellectual discharges, or electroclinical seizures, or electrical seizures, or in the case of psychogenic non-epileptic seizure, we just capture episode in the video with no change in the EEG. Okay. So then, as I mentioned before, in the inpatient video EEG monitoring, we have the liberty of stopping all the medicine and performing hyperventilation, photic stimulation, sleep deprivation during the test. And so in the ambulatory, in the first day when you hook up the patient, we do the hyperventilation and photic stimulation. And then the patient come back, you download the data, we make the report, then we put into different categories. The patient has epilepsy, psychogenic, non-epileptic events, and epilepsy, what kind of epilepsy. So this is our just overview of the data. In the ambulatory video EEG monitoring, female and male patients are kind of almost the same, but inpatient EEG monitoring, and female patients are more than male patients, and the race and ethnicity reflecting the Central Valley. So the result is like a very depressing, to be honest with you. So for example, like out of the 120 ambulatory video EEG monitoring we performed, so 92 patients we didn't record nothing. And then inpatient video EEG monitoring, we performed 94. Out of them, like 37 patients, we didn't record nothing. But the thing is that we have several layers of monitoring. So first, when you do the EEG, our very dedicated EEG technologists, they review the EEG and then come to my attention. I painstakingly review everything, and in spite of that, the yield is very less. So then, what is the yield? The distribution of the yield is like electroclinical seizures, obviously is more in the inpatient video EEG monitoring and very less in the outpatient EEG monitoring. And intraventricular discharges also more in the inpatient EEG monitoring and less in the ambulatory video EEG monitoring. But the gap is not that really great. And very few electrographic seizures recorded in the inpatient video EEG monitoring and none in the ambulatory video EEG monitoring. So then pre-test versus post-test diagnosis of epilepsy and other spells on ambulatory video EEG monitoring alone. So out of the 120 ambulatory video EEG monitoring we performed, so 104 patients we diagnosed with epilepsy. So the epilepsy means the majority of them have focal epilepsy, then 67%, and generalized epilepsy 15%, and epilepsy unclassified is 11%. And we thought 11 patients have psychogenic non-epileptic seizures, but actually we can prove it only in 5 patients. So then the pre-test and post-diagnosis yield based upon the inpatient video EEG monitoring. About the 94 patients, before sending to the EMU, we thought 79% patients have actually epilepsy, but we can confirm the epilepsy, including the intraventricular discharges and seizure, only 25% of the patients. And out of the distribution, again, it's all kind of expected, more focal epilepsy, more generalized epilepsy. And psychogenic seizures, we thought, before sending the patient, we thought patient has psychogenic episode, and actually we captured psychogenic episode. And some of the patients we thought actually epileptic seizures turned to be actually non-epileptic seizures. But the common concept, if you read the literature, it is the other way around. Ambulatory video EEG monitoring is that patient is living in their stress environment setting. You can really capture psychogenic episode, not in the inpatient video EEG monitoring. Our experience is not. So the conclusion is, there is nothing really, groundbreaking discovery or anything. Inpatient video EEG monitoring in the EMU is superior yield to ambulatory video EEG monitoring in classification of spells, and is the option of choice when resources are sufficient. And so the other part is one thing everybody say, ambulatory video EEG monitoring is very cost effective, much cheaper. But the problem that if you have a negative test, I showed that it is so much negative, we need to repeat the test 2 or 3 times. So when you're adding up all the cost to bring the patient back and again, I think it is at one point of time it is going to be equalized. I don't know if this is really effective or not. So one more thing I want to the video interpretation of the semiology based upon the different syndromes and psychogenic is a physician's expertise, right? So now everything is taken away with the AI. There are a lot of AI tools are developing just based upon the behavior and the motor manifestations patient is expressing, more definitely categorized into what is it, epileptic seizure, psychogenic, or epilepsy seizure, what type. So, maybe in next 5 years, the AI is going to replace the way we are going to do the EEG AI is going to replace how we are going to look at the video too. So if you have any questions, please ask. Sure. Correct, yeah. Yeah. Correct, yeah. Yeah. So, I have like a working relationship with the USA, and also, every week we have Wednesday patient management conference, and Zoom we participate and we present our cases. And again, the monitoring is like our theoretically on in the seriousness base, right? Really, really bad epilepsy or like some low-grade glioma causing seizure. That's always the priority. We try to do that. But sometimes, it is not under my control. I tell them, but the insurance has to approve, the tax has to monitor. There is no 100% control of this is happening. But generally, agree with it. And then we discuss the case in the conference, and then, we'll make a combined decision. But some of the cases, I do think that it is not aligning with my philosophy. I refer to other places too, UCL, ULA, or UCSF. When I was trained in Cleveland, we have an Eastern way of looking to this epilepsy approach is very different from the West. I will tell you that. And I don't want to get an argument with other people. The way we think is a very, very different way. Even the thing is that my actual belief is that the current technology is not capturing what is happening at the cortical surface level, because it is far away from the brain. Actually, they're you're looking at the different scales, micro scale, all the neurons and the wire, they're connected. So that is a different scale what we are measuring at the scalp, the time scale as a spatial scale. So, but still the AI is going to be so better. When you have these undulations happening on the surface EEG, it will be smarter than me and everybody else in this country to tell there is really something happening down that actually is pointing the epileptic abnormality. That is going to happen. Uh-huh. Yeah, yeah. Yeah, you're really very interesting point you raised. Actually, we looked into, but I didn't get the official permission from the billing department to show it in the conference. But it's huge difference. Ambulatory is much cheaper than inpatient EEG monitoring. But my point of against this is if you're repeating this 2 or 3 times, it is going to be like comparable. And also, patient is living for years without having any proper diagnosis. Then, so if I'm not starting a medicine, if the patient is going to event with a different hospital, they are going to start some seizure medication. Yeah. Any other questions? Thank you very much for listening to me. Okay, appreciate it. Thanks. Bye.